Good afternoon, everyone, and welcome to today's webinar discussing new directions in diabetes prevention for Black Americans. I'd like to thank you all on behalf of the Council on Black Health, formerly known as the African American Collaborative Obesity Research Network, ACORN, and the Center for Diabetes Translation Research at Washington University, St. Louis, for your participation this afternoon and interest in this topic. During the presentation today, we ask that you post questions using the Q&A button in the Zoom webinar interface. We will review and select questions for our presenter to respond to after the presentation. If your question was not selected for response, we will share follow-up feedback after today's session. Please feel free to use the chat window to interact with fellow attendees during the session this afternoon. Also, this presentation will be recorded and archived for future viewing. We will publish the webinar online and share the link via email. My name is Sheldon Oliver Watts, and I am the National Director of the Council on Black Health, also known as the Council. The Council is the new identity for the African American Collaborative Obesity Research Network, a collaborative network of scholars and community-based research partners located in over 20 different states. The Council's mission is to develop and promote solutions that achieve healthy Black communities. Our national office is located at Drexel University's Dornsife School of Public Health in Philadelphia, Pennsylvania. The Council leverages the credibility and perspectives of Black American researchers and research partners to facilitate more relevant, community-engaged, high-impact, actionable solutions that positively impact Black communities. I'm also the core manager of the Solutions to Diabetes and Black Americans Core at Washington University's Center for Diabetes Translation and Research. As a Disparities Core, we provide methodological and content expertise to develop innovative approaches that advance the field of diabetes research in Black Americans. Today's session will discuss new directions in diabetes prevention for Black Americans. The Diabetes Prevention Program, or DPP, provided strong evidence that modest weight loss could reduce the onset of diabetes by half among persons at high risk for diabetes. In DPP and other intense behavioral weight loss interventions, Black participants lose clinically significant amounts of weight, but among Black women, weight loss outcomes are generally among the lowest. This webinar will present research summarizing the weight loss outcomes of Black Americans, mainly women, participating in trials of DPP adaptations, and then highlight more recent studies that suggest new approaches to designing behavioral weight loss approaches for Black Americans that show promise in improving observed weight loss outcomes. Our esteemed speaker today is Carmen Samuel Hodge. Dr. Samuel Hodge is a research professor in the Department of Nutrition at the University of North Carolina, Gillings School of Public Health and School of Medicine. With a background in biology and nutritional science, she first worked as a public health dietitian for 9 years and later completed her doctoral training in public health nutrition at the University of North Carolina at Chapel Hill. Dr. Samuel Hodge's research is focused on clinical and community-based diabetes self-management training interventions among African Americans with type 2 diabetes, behavioral weight loss interventions, weight loss maintenance, and lifestyle interventions using peer counselors, community and church diabetes advisors. Her major research interests include behavioral issues related to lifestyle behavior change and weight management, intervention research focused on nutrition in chronic disease risk reduction and self-management, health disparities and translational research, family functioning among African American adults living with chronic diseases, and family and community-based behavioral lifestyle interventions. Dr. Samuel Hodge has served as the principal investigator on several research projects funded by the Centers of Disease Control and Prevention and the National Institutes of Health, National Institute of Diabetes and Digestive and Kidney Diseases, and National Heart, Lung, and Blood Institute. As a researcher at the Center for Health Promotion and Disease Prevention, she is currently the co-principal investigator for the Carolina Heart Alliance Networking for Greater Equity Core Project. She also serves as a translational and implementation research specialist at the Granville Vance District Health Department. I'd like to invite Dr. Samuel Hodge to now open our presentation today.
All right, thank you, Sheldon. Good afternoon, everyone, and thank you for taking the time to participate in today's webinar. Today's presentation will focus on weight loss outcomes of African Americans in behavioral weight loss interventions that were based on adaptations of the diabetes prevention program. I will start by sharing with you the findings of a systematic review that I conducted with my colleagues and published in 2014, and then follow with some findings specific to African Americans from more recent adaptations that offer ideas for new approaches. So when this topic was first pitched to me by Shariki, she spoke with me about doing this webinar and asked that I should start with a systematic review and then focus on some of my more recent work. And so that's what I plan to do today. And I will also include a couple brief summaries of 2 other studies that relate to this topic that have been published recently. So that will be the what's new. And then where do we go from here is where we summarize what these new studies, these adaptations have suggested. And then what I would like to do is share my ideas of where we go from here and invite you to share yours as well, because I don't think we know exactly where to go. We have some ideas, but it's not as clear as we would like it to be. So here we go. All right, so the first thing I'll go through are the results from the systematic review. And that one was published in 2014, and it's entitled The Effectiveness of Diabetes Prevention Program Translations Among African Americans. So Sheldon began by giving a sort of a brief overview of the DPP program. So essentially, this is a repeat of what he said. It's an intense behavioral weight loss intervention. It consists of a 16-week core curriculum that's delivered over a 24-week period. And the components of this program include moderate restriction in calories, recommendations for restriction in terms of the percent fat in the diet. There's also a behavioral component and a physical activity component. And the DPP recommended 150 minutes of moderate level physical activity per week. The weight loss goal for DPP was 7% of initial body weight. And because of the effectiveness of this program, it was actually shown to reduce the risk of diabetes onset by 58%. So this program has strong evidence in terms of modest weight loss producing a benefit in terms of reducing the risk of getting type 2 diabetes. All right, for the systematic review, we focused on adaptations of the diabetes prevention program, and in particular, those that were done among African Americans. And the reason for that was that even though 22% of DPP participants were African Americans, we saw that African American women did not do so well even with this intense behavioral weight loss intervention that's considered sort of a gold standard. So they had the lowest level of weight loss success. And you can see the percent of initial body weight loss by the different subgroups. So African American women lost about 4.9% of their initial body weight, followed by African American men, who lost about 6.6%. And then Hispanic men and women lost about 7.3 to 7.7%, with white men and women losing the most. White women at 7.9 and white men at 8.5%. And put all of this in the context of the rates of obesity among African Americans in this country, which are particularly high among African American women. So the whole idea that those at greatest risk are actually losing the least amount of weight with this intervention poses an issue for us to find ways to address. So that was the impetus for the review. All right, so what we did was we included studies in this systematic review that were adaptations or translations of the diabetes prevention program with a focus on weight loss with the core program components. We included studies that included participants who already had diabetes. And one of the reasons for that is that we were really looking at DPP as an intense behavioral weight loss intervention. We included studies that had at least 10 African Americans. If they had a mixed sample, the number of African Americans had to be at least 10. And any study that had all African Americans, we accepted all of those studies, even if they had less than 10 participants. We only included studies that had a minimum duration of 3 months. And the reason for that is we anticipated that that duration would be a period that would make losing about 5% of your body weight feasible. And we also looked for studies that reported the amount of weight loss by African Americans in the study. So those were the main components of the studies that were included in the systematic review. So we initially screened over 1,000 records, and from those records, we assessed 21 full-text articles. And then from that subset, 17 studies were determined to be eligible for a review. And of those 17, 7 studies included only African Americans and 10 studies included mixed samples. So here's a summary of the 2 categories of adaptation studies that were included in the review. There were 7 studies that included all African Americans, and in that group, 3 of the 7 were randomized controlled trials, 4 were single treatment quasi-experimental designs. 4 of the studies in this group were conducted in churches, and all of the interventions were group-based. In the studies that included only African Americans, 70 to 100% of the participants were women. And as you can see, some of the sample sizes were quite small, and the range is quite large. So the smallest study had 8 participants, and the largest over 300. The duration of the studies in this group started as low as 12 weeks, which is about 3 months, up to 6 months. So those are the characteristics of the studies that included only African Americans. In the next group, which included both African Americans and non-African Americans, there were 10 studies, of which 9 were randomized controlled trials. And the proportion of African Americans in these studies ranged from 14% to 82%. And the percent women ranged from 58 to 100%. As you can see here, the number of participants in these studies, which was much larger, and the duration of the interventions, the DPP adaptations, ranged from 12 weeks to 12 months, so a much longer period for the intervention. Another point to make about the mixed sample was that 6 of those 10 studies were conducted in healthcare settings. So that was another difference. The all African American studies were mostly conducted in churches, and the mixed samples were largely conducted in healthcare settings. All right, so some of the types of adaptations that were identified in the studies that were reviewed included adding components such as motivational interviewing, emphasizing stress management, adding extra enhancements for social support, And many of the church-based interventions, adaptations, included prayer, Bible study, and goals that were related to faith. The adaptations also had different formats. Some included in-person visits, phone-based delivery, and group-based delivery. So there were many different types of delivery formats in these adaptations. And in terms of settings, as I mentioned before, most of the African American only studies were faith-based, and those with mixed samples were primarily in healthcare settings. All right, so this is just a summary table of the key characteristics and outcomes of both categories of DPP adaptations, and they're put there right next to DPP itself so that you can look at how they were similar or different. So as you can see with this table, the mean age, the participants in these studies tend to be mid-age, around 50 years of age. And again, most of these studies included mostly women. So you can see DPP was 68%, and the two groups of DPP translations included about 88 to 89% women. If you look at the attendance, and the reason we're putting that there is because, as an important characteristic, is because we know from much of the weight loss literature that attendance relates to weight loss success. And so looking at the mean attendance, comparing the translational programs with DPP, you can see, and it's not a fair comparison because DPP was individually delivered, so you would expect their attendance to be much higher. But as you look at the two different categories of DPP translations, you'll see that the studies that involved only African Americans had a lower attendance rate. You can see that it's about 56% for the translational DPP studies that included only African Americans. And for the DPP translations that had mixed samples, the average attendance was 62%. And attrition is also listed there. And you can see again that higher attrition rates in both forms of translation, both the African American only and the mixed samples. The intervention dose differed quite a bit among all of the studies that we reviewed, but you can see the mixed sample adaptations had a larger overall number of contacts, so the dose was higher in that category. And then in terms of outcomes, the box at the bottom includes the short-term outcomes. So those are the outcomes immediately post-intervention. And you can see for DPP itself, for African Americans, the average weight loss was about 5.8%, 5.8 kilograms, and that included men at 6.8 and women at 4.7. But if you look at the two sets of diabetes prevention program adaptations, you'll see that the weight loss is much lower at 2.9 kilograms for the African American only ones, and then 2.6 kilogram weight loss for those with mixed samples. For the weight loss rate, so what we did here was, because many of the programs had different lengths and different number of contacts, what we did was calculated a rate of weight loss based on kilograms per month. And so if you look at that metric, you'll see that in DPP, it averaged about 1 kilogram per month for African Americans. And in both of the translational categories, you'll see that it's a little bit less but higher in the DPP translations that include only African Americans at 0.7 of a kilogram per month, and in the mixed samples, about 0.5 kilogram per month. So that gives you an idea of how the translational DPP interventions compare to the original. And you can see that the weight loss outcomes were not as good. All right, this is just another way of comparing the weight loss outcomes in those two categories. And what we did was we divided the studies into what we consider to be higher quality studies. And the higher quality studies were considered to be those that were randomized controlled trials by design that had samples of greater than 30 and used intention to treat analysis or had attrition rates that were less than 20%. So those studies are on the left. And what we did was we put their outcomes relative to the DPP outcomes, which are reflected on this in this figure with the solid line for the mean weight loss in DPP in kilograms, and then the dotted line below with the rate of the mean kilogram per month weight loss based on DPP. So those two lines are sort of your reference lines so that we can interpret the outcomes for the studies that were in this systematic review. And the dots on the screen indicate the studies that included only African Americans. So again, you can see that pretty much only one study had weight loss outcomes that exceeded that of the DPP in terms of mean kilograms of weight lost. And that's the Perry study. It's on the side with other studies and not the higher quality studies, only because during the weight loss phase for that study, they did not randomize and they did not use intention to treat analysis. But their outcomes are really good, and we'll talk about what could potentially explain that later on. So again, if you look at the total weight loss and the kilograms per month weight loss, you can see very few of the adaptations of DPP met that mark. So the Perry study did, Dodani did, and the Cox study did. And the Cox study here is a study that used the stress management adaptation as a way of enhancing their weight loss program. So that one actually had an average kilogram per month weight loss that was similar to that of DPP. Okay. All right. So in summary, a number of the studies had very small samples, especially those that included only African Americans. We also saw there was higher rates of attrition in studies with only African Americans. And again, remember, most of those studies were group-based. We also saw that, in general, all of these DPP translations were less effective. And about the weight loss outcomes were about half of the mean weight loss of DPP. So some of the factors that could be associated with this difference in effectiveness are the frequency of contacts, in other words, dose of the intervention, and attendance. So those are factors that could potentially be explaining the less than optimal weight loss for these adaptations. One other factor that could potentially be explaining some of the effectiveness that we're seeing with the adaptation is that training for implementation, training staff for implementation, and also monitoring the extent to which they're actually delivering the intervention as intended becomes an important factor, and it might potentially be influencing the level of effectiveness. Thinking back to the Perry study, which showed the mean weight loss exceeded that of the DPP program, that particular study had really strong training of its implementation staff. I believe their training component was about 70 hours of training for staff, and there was extensive monitoring of the delivery of the intervention. So that could potentially explain some of their outcomes in terms of the level of effectiveness. One of the other things we see with these adaptations of DPP, that there are some groups that are not well represented, and they include men, younger adults, and lower income populations. So those are three areas where we actually need a lot more research in figuring out what programs will work best for them, what adaptations are needed to meet their needs. From the adaptations that we saw in this review, some of the things that are promising from the outcomes that we observed are the enhancements you get from supporting the person losing weight with friends and family, and that was seen in Shariki's SHARE study, and including stress management skills into the core pieces of the DPP program. And these stress management skills include things like relaxation techniques and behavioral and cognitive strategies. And that was the adaptation or the enhancement used in the Cox study. So those are two promising adaptations observed in the programs that we just looked at. All right, moving on to what's new. So what are some of the adaptations that have happened since this systematic review was published? So the first one I'd like to share with you is a study that I conducted called Family Pals, which stands for Partners in Lifestyle Support. And this is a family-based weight loss intervention and is designed for African American adults with type 2 diabetes. So starting with the basic core elements of the DPP program and other evidence-based interventions, we designed a family-centered behavioral weight loss intervention for African Americans with type 2 diabetes who would go through the program partnered with a family member, an adult family member who was not diagnosed with diabetes. So the index participant is the adult with diabetes, and they're paired with an adult family member who did not have diabetes. Now, this family member could be a spouse, it could be an adult child, it could be a cousin, a sibling, any other family member who regularly interacted with a person with diabetes was allowed to be the partner in this program, in this study. And we built the family-centered component of this intervention on constructs from social independence, which talks about cooperative or positively influencing the actions of the individual by the engagement with another person. So that component includes elements of social support, but not just social support. So it's not just a social support enhancement. It also includes effective communication, so communicating between the index person and family members and the family partner who doesn't have diabetes, having that communication be sound and effective, and also constructive management of conflict. So those were the key elements in designing this particular family-centered intervention. So the Family Pals adaptation included 20 weekly group-based sessions that lasted about 2 hours. We had dyads or pairs of index and family partner groups, 10 dyads in each cohort. The dietary pattern we promoted for this particular intervention was, it was not low fat. It really promoted more of a Mediterranean dietary pattern style. So we really focused on high quality fat and high quality carbs as a dietary pattern. We bumped up the physical activity to 180 minutes per week recommendation. And probably the key component here is that we added to pretty much the DPP core components, we added what we call family time components. And these components consisted of 20 minutes in every other session. So in that 20-week program, we had 10 sessions that were specifically focused on family time. And the way we came up with the family time components was, we initially did focus groups with adults who were living with diabetes and family members who were living with adults with diabetes. So we did focus groups with both groups. We took that information in addition to quantitative information we collected from surveys that measured family interactions, things like conflict resolution, cohesion, connectedness, all of that. We did surveys that gathered that information, and we put the qualitative and quantitative information together, took that to a clinical psychologist who has had a background in family therapy and marriage therapy, and had her work with us to develop those family time components. So that's the basis for the components that were added to this weight loss intervention. And the reason we did that was because a number of family-centered interventions are not theory-informed, and they don't include guidance from somebody who actually knows how to address those issues. So we felt that it was really important that we not just design these pieces as you would if you're a dietitian or somebody who's accustomed to weight loss interventions. We felt it would be really important for somebody with that expertise to guide the development of that component. So that's what we did. And we did it with both quantitative and qualitative data. So when we looked at both the quantitative and the qualitative data for coming up with this family time component, we found that the issues that needed to be addressed within these family time components for the intervention should deal with unresolved diabetes conflict, communication, cohesion, support, and problem solving. So those were the key concepts for which we developed activities to include into the Family Pals intervention, to be very intentional about addressing these issues within that intervention. And again, this information came from the focus groups and from the surveys. So Family Pals was a randomized control waitlisted. The control group was waitlisted. There's a randomized control trial. We did a 2-to-1 allocation so that more participants would have a chance to receive the intervention. So in that sense, we had 54 dyads total. 36 of them were in the intervention group, and 18 were in the waitlisted control. And our primary outcome was weight loss in the index participant, which is the patient with diabetes. But we also measured the family members. So we have outcomes for both the index person and their family partner. So the participants in this study included 81% female with a mean age of 51, which is similar to most of the other adaptations we looked at earlier. The mean BMI was 37 with a mean weight of 103 kilograms. So in terms of the dyads that participated in the study, 30% of them included a family member who lived in the same household as the index person, and 27% of the dyads included a spouse. We had good retention in the study. We were able to get follow-up measures on 89% of the sample. And we looked at our weight loss outcomes using intent to treat. And we found the difference between groups was 5 kilograms, with the weight loss for the intervention group being 3.6 kilograms. And the control group actually gained weight during this period of time, this 5-month period. So those are the unadjusted results using intention to treat. If we look just at the completers, we find that the difference between groups, the intervention group and the control, was almost 6 kilograms, and the participants in the intervention group lost 4.3 kilograms, controls gained about 1.4. But more importantly, about 42% of intervention index participants lost at least 5% of their initial body weight, whereas none of the controls did. The attendance was reasonably good, 75% on average. And for those participants who came to all 20 sessions, the weight loss was even higher at 7 kilograms. So this is what we observed in our family-centered intervention for the index participant. And remember, the index participant is the person with diabetes. And people with diabetes have a really hard time losing weight. So we were really pleased with the weight loss results that we found among our index participants. For the family partners, our adjusted mean weight change was 4 kilograms in the intervention group and half of a kilogram in controls. And in this group, 38% of them lost at least 5% of their initial body weight. So if you put both groups of family partners together, about 28% of them lost at least 7% of their initial body weight, and 40% lost about 5% or more. So again, within the family partners, we also saw good weight loss. So some of the other outcomes for this study, we also looked at the family interactions, and they were significantly improved in the intervention group. Family cohesion improved, and support for diet and physical activity were also significantly improved in this group. What we found was that attending sessions together was really important. Not just attending the sessions, but attending the sessions as a dyad actually made a difference. So the dyads that attended more than 10 sessions together lost about 2.4 kilograms more than those who attended fewer than 10 sessions together. So that tells us something, that there's something about that cooperative effect of being in a dyad that helps with the weight loss outcomes. We also found that index participants lost more weight when they were paired with a family member who lost at least 5%. So you're seeing the effect of the partner on the index person and vice versa. So that's one of the more recent adaptations of DPP, and in this case, the adaptation was adding a family component to the core components of the DPP intervention. This is the second study I want to describe in the next few minutes, and this one looked at an adaptation that was based on the Mediterranean dietary pattern, and we looked at this among participants who had diabetes in a project called the Heart Healthy Lenore Project. And Lenore is a county in North Carolina that has a high rate, it's a rural county, it has high rates of poverty and a large proportion of African Americans. And so what I'll describe to you is an intervention that we did in this setting among rural, low-income, mostly minority populations. So the adaptation here is not only the dietary pattern that we use in the 16-week weight loss intervention, which is essentially just the DPP core with a change in the dietary prescription. But what we did is we preceded the intervention, the weight loss intervention, with a 6-month phase where participants just learned how to change their dietary and physical activity behaviors, where there was no expectation for them to lose any weight. So we did that for 6 months. Everyone started in the lifestyle intervention, and then they moved on to weight loss only if they chose to do so. If they didn't want to lose weight, they could continue in a lifestyle intervention up until the second year, up until 24 months. So it's a 24-month period. And if you started in lifestyle, you could go all the way, but you had a choice at 6 months to become a part of a 16-week weight loss intervention. So the lifestyle intervention in this particular study focused on a Mediterranean dietary pattern. And during that initial 6-month period, there were 4 individual or group-based counseling sessions. So it's a low-intensity intervention. And again, the focus was on just changing dietary and physical activity habits. And everyone started there. For those participants at 6 months who wanted to go into the weight loss intervention, they were given that choice. The weight loss intervention was your standard 16-week behavioral weight loss program. But we did it in 2 formats where one group had all group sessions and the other had a combination of phone and group sessions. And then in the maintenance phase, it was just phone contacts that were quarterly. So the participants in this one were 124 participants with diabetes and 130 without, and I'll focus on the ones with diabetes. Most of them were African Americans and mostly women. As you can see here, the educational attainment is pretty low, which tends to be common in many rural parts of the state. So the weight loss outcomes that are presented here in this table are for all the groups going through this entire program. So not only the 2 groups that were in the weight loss program, but also the group that remained in the lifestyle program all the way to 24 months. And so what you see here is weight loss from baseline to 6 months of about 1.2 kilograms, then up to the 12th month, 1.5, and then by 2 years, 3.7 kilograms. And this includes people who did not even plan to lose any weight. So when you look at the next screen, you'll see the weight loss outcomes for the 2 groups that chose the weight loss intervention. And for those, we see that the weight loss at 12 months was 3.9 kilograms, and at 24 months, 5.2, with 44% losing at least 5% of their body weight. And that's in the group-only format. In the group plus phone, the weight loss outcomes were smaller, and you can see them listed there. But overall, by 12 months, 24 months, by 2 years, 34% of participants with diabetes lost at least 5% of their body weight, compared to 16% for those who did not have diabetes. So the participants with diabetes seem to be more motivated to actually lose weight. So from this one, we see that Mediterranean style dietary pattern led to sustained weight loss among this low-income, rural, mostly minority sample of participants with diabetes. So we're thinking that aspects of that dietary pattern actually allowed folks to not feel deprived and feel as if they could stick with that pattern for the long haul. The group format obviously showed much better results than the combination format. And we're thinking that starting with just lifestyle changes with no focus on weight loss may have also been an important factor here. So those are the three things to take away from this particular example. And there are just two other studies I'm going to talk very briefly about just to make sure that we leave enough time for questions and answers. But this one, Power Up for Health, is an intervention that was designed for men, and in particular men in an urban disadvantaged setting who are African American and Latino. And so this just gives a basic idea of the participants and the outcomes from this study. So again, it's an adaptation of DPP. It's a pilot study, so the sample size is pretty small. And you can see what the mean age, mean BMI, similar to what we've seen in all the other adaptations. And in terms of the outcome, the weight loss was about 3.8% of initial weight. And the fact that 3 of the 5 sites achieved a mean weight loss that was over 5%, the reason that's significant is because that's one of the outcomes that's required for if you're seeking CDC recognition status. One of the things they want from your DPP programs is that on average, the weight loss is 5% or higher. So that's why that outcome is meaningful. And the mean attendance was pretty high, 11.6 sessions of the 16. As you might imagine, recruitment of men was challenging. And so I think this group feels as if they've learned a lot from this pilot, and they plan to sort of refine their approach as they move along. This next one is a faith-based adaptation, and it's called Fit Body and Soul. And you can see, again, it's the same basic age category and mostly female characteristics of the participants, but this one is a randomized controlled trial where the control group gets a health education-based intervention. In this particular study, they did not include people with type 2 diabetes, and it's 12 weekly group sessions. And you can see their outcomes here. Look very similar to some of the adaptations we saw in the systematic review in terms of weight loss. All right, so that's what we have with the weight loss adaptations that are based on DPP for adaptations that are based specifically for African Americans. So where do we go from here? We obviously have a long way to go because we still are not getting to the place where the effectiveness is even reaching the limit that was observed in DPP. What seems to be important in the approaches that have been taken to enhance the outcomes for African Americans, and we might as well say that these are mainly designed for women because that's who most of these adaptations were included. The family-centered or dyadic approach seems to have promise. We still have a lot to learn in terms of who the partners should be, how should they be involved, when should they be involved, and the nature of the involvement. But we do know that that makes a difference. And we've seen that not only with the Family PAL study, but with the SHARE study conducted by Shiriki. So those two give us an idea that this is a viable approach. We just need to refine it. The stress management focus is also meaningful in the sense that many of the issues related to weight, diet, and physical activity among African American women can be traced back to chronic stress and the reactions to it, whether it's through the way we eat or physical activity behaviors. And so to the extent that we have cognitive and behavioral skills that address that, that is an approach that needs a lot more work. Because in all of this work, we have to take the main concepts and then adapt them so that the stories we tell to the participants resonate with their lives in such a way that they can make the behavior changes or make the cognitive changes. The intervention with the Heart Healthy Lenore study, I think, tells us that potentially it might be meaningful to start off with just a lifestyle change component or phase before jumping right into intense weight loss. And we've seen that not only with our study, but with other studies where they start off with what they call maintenance first, and then you go into an intense phase. And what they find is that with that approach, the weight loss maintenance is much better sustained over the long term. So that might be an approach that makes more sense. And of course, a lot of what we do for African American populations that work well involve group-based. But we also need to figure out how to create groups that are not in person, but have the same elements that make people feel connected. So potentially designing online group-based interventions might be something that we really need to consider and figure out how to do well. Let's see. And the only other piece I think I'd mention here before we go to questions is that we need to figure out if the amount of weight loss is the most important thing or how the weight is lost in terms of its benefit to African American subsamples. Because we no matter what we do, we find that there's a smaller amount of weight loss. Then the question is, are the benefits smaller? Or are we getting similar benefits with a smaller amount of weight loss? So I'll end with that since we only have about 6 minutes left. And I want to thank you for your time, and I look forward to sharing your ideas as to how we move forward.
So thank you so much, Dr. Samuel Hodge. It was a very interesting presentation, and hopefully we'll have some questions in these final minutes that we have here for your presentation this afternoon. So if you do have any questions, please feel free to click on the Q&A box in your Zoom interface, and you can type in any questions there, and we'll make them available. And just on your closing note, Dr. Samuel, I was interested in that comment that you made about, whether or not these smaller changes in weight had a potentially greater impact on the African American population or the Black population, where you've been looking at some of these key adaptations. And I was wondering, in terms of outcomes, was there any measures that you all looked at or was shown in any of these studies that looked at the impact that weight change had on, say, A1C levels and, kind of blood glucose management over time as a consequence of participating in these trials?
Yeah, there are a number of the outcomes really relate to like blood pressure changes and changes in A1C, and you can see those changes with even weight loss outcomes that are smaller than that 5% that's considered the clinically significant amount of weight loss. So we've seen that in African American populations, and there was a review done by Jamie Ard and his colleagues that looked at weight loss, the magnitude of the weight loss, and the sort of the physiologic benefits. And they looked at what they found was that for a lot of the studies that were hypertension related, even with a smaller amount of weight loss, the benefits were equivalent to the benefits seen in non-African American populations at a higher weight loss. So we know in that context, you can see equivalent benefit with smaller amounts of weight loss. And so the question is it the amount of weight, or is it how the weight is lost?
Sure.
That makes the difference. So I think we need to look at that a little bit more.
Yeah, I'd be especially interested in those trials that also include physical activity, because people are becoming active. There's metabolic changes that are happening. People are becoming more, sensitive to insulin, and it potentially can have an even greater impact on diabetes management. Another question that I had was related to how some of these DPP trials might have been adapted. I know you had talked a bit about some faith-based interventions. You had also talked about some others that were done in different settings, and as well as the family dyad. Is there anything that can be said about a particular type of adaptation in terms of its overall effectiveness with the DPP? I'm wondering if some of the studies that you looked at primarily for the systematic review were adapted culturally or had some type of ethnic adaptation for the populations that they were provided for?
Yeah, many of them included adaptations that were based on where the intervention was held and who delivered it, in addition to components of the intervention that were adapted for an African American population. So like the food and the type of physical activity that was included, that sort of thing are common components of adaptation.
And we have one question that came in as it related to the PALS intervention that you discussed, and it relates to the type of diet. And I know you had mentioned that there were variation in terms of the type of diets that you all in some instances there were couples, there were spouses, in some instances members. Was there any difference in the effectiveness of the program for the type of diets that you all observed in that particular intervention?
Yeah, so one of the reasons we made that the choices for who you brought in as a family member so broad is because we know that, African American families are they look at the extended family as family. And so we made it really broad. But I think one of the things we found was that we saw differences in the spousal combination dyads. So if a female index person, so a female person with diabetes came in with a spouse as her family partner, she did not do well at all. If the male was the index person and his family partner was his spouse, he did really well. So that was one of the interesting things that we found in PALS. The sex of the index person coming in partnered with a spouse made a difference. That was the only thing that really stood out.
Interesting to look a little deeper at that question.
Yeah, but our sample was not as big as we wanted it because it was part of my K award, and I really need to do the study again with a larger sample.
Sure. Well, I think we're running short on time now. We're coming just around 2 o'clock. So I'd like to thank you again, Dr. Samuel Hodge, for sharing your research with us today, for talking about some of the new work that's been done in adapting the DPP program in various settings. And I'd like to thank you all for participating in the Solutions to Diabetes in Black Americans webinar, New Directions in Diabetes Prevention for Black Americans. We will be emailing a follow-up evaluation survey shortly, and we will share a video of this webinar with everyone who participated today, as well as everyone who we shared this presentation, the announcement of this presentation today. So thank you. Enjoy the rest of your week. And thank you again, Dr. Hodge.
You're very welcome. Thank you.